Awesome. So hello everyone. My name's Emily. I'm a current second-year resident, also one of the membership committee of the RFS co-chairs along with Lynsey. And then Subhash is one of the amazing med students at George Washington University. And we've been putting together this series kind of going over different practices that IRs can be in beyond training, and kind of to expose everyone to different practices that, you know, exist beyond the academic practice that we more typically see during our rotations. So we're really happy to announce this third webinar of our series, focusing on IR and rural practice settings. So we have Dr. Solberg here with us. Dr. Neal Khurana is also supposed to join. He's doing an emergent case right now, though, but will hopefully join us as soon as he can. So with that, we'll kind of get started. And if you guys have any questions kind of during the webinar session, just feel free to answer them either in the question tab or the chat, and we'll try to get to those at the end. So this is just our contact information. This will also be at the end of the presentation for anyone who needs it. So I guess just to kind of start out, we'll do some speaker introductions. We have a couple guiding questions to kind of go over the different things that only exist in rural practice that we might not really be exposed to as trainees in a more academic or urban setting. So with that, we'll kind of get started. So Dr. Solberg, just kind of tell us a little bit about yourself, your backgrounds, how you got to be where you are, you know, how you got to be at your current practice.
Sure. Hi, everybody. My name is Agnes, and I'm an interventional radiologist and also do a little bit of diagnostic work as well. And as far as how I got to this rural practice is I married a boy from North Dakota, and I moved here for love. So I live in Bismarck, North Dakota, which is the capital city, but it's still a very small city, under 100,000. So the whole state has about 500,000 or 600,000 population. So there are definitely some challenges as far as that. And as far as a little bit about me in the past, I'm originally from Poland, moved to the US when I was 10. So did all my school here. I actually did most of my medical training in the US military. I left that. I did internal medicine residency and nuclear medicine residency in the military. I left the military, then I did diagnostic radiology and IR. And I've only been out of IR fellowship for years, but it was a long road. And after each of those training programs, I worked for a couple of years. So, so that is that. I got a job at I was essentially a hospital employed physician for CHI St. Alexis Health, which is one of the two main hospitals in our town. And 2 years ago, I transitioned from a full-time contract to a PRN contract, and all of our interventionalists did at that time due to some restructuring. I do some teleradiology work on the side just to keep, you know, regain some of the skills I've lost doing 100% IR for a while. And that's been a lot of fun as well. So
nice. And so how did it sounds like you got into North Dakota from, you know, finding love and following your husband. How do you find that, you know, working in a rural setting kind of differs from like what you might have seen during your training or especially in the military?
Sure. So there are definitely some challenges, and some of the biggest challenges will depend on the hospital, like the rural hospital or practice where you work. And, you know, my hospital is not that large, but it's still a tertiary referral center for the smaller hospitals. They don't have any interventionalists at all. You know, patients will be sent from as many from 4 to 7 hours away. I mean, I have patients driving to my clinic. They stay in a hotel, like they'll drive 4 or 5 hours. And so the practice model definitely changes when your patients are driving that far to see you, because you can't like look at your imaging ahead of time for, you know, IO follow-ups and things like that. And then your hospital may not have all the resources that you need to do certain types of cases on certain days, and et cetera, et cetera. So there are a lot of logistical limitations in how that practice is structured. Despite all these limitations, we still do a pretty full breadth of IR at our institutions. You know, I refer, you know, pulmonary AVMs because I've done, you know, one since training, and it's just not, you know, it's just, so things like that. But most things we do here, you know, there are some things that we do refer out, but it's not very common.
Yeah, this kind of goes into like some of the questions that we kind of had built up. So like, what is your patient population like? Like how many, it sounds like you get referrals, like how many people live in Bismarck in general? And then what would you say is kind of like the catchment area of places that you get? Is it primarily just the surrounding state? Do you get other states that come to see you?
Yeah, so obviously about 3/4 of my patients they live in town or in a town hour and a half and 2 hours away, or 2 other towns. That catch area I think is about 150,000. And then there are other people that drive further than that. We have pretty North Dakota. I mean, it's not a very diverse population here, I'll say. Although we do have Native American reservations, and we like to help a lot of those patients. As far as the kind of the caseload, like obviously there aren't enough patients here for me to do complex interventional high-end things, you know, every day, all day, right? So as far as like the caseload in the rural practice, you know, I do spend time during the day doing like thoracentesis, paracentesis, thyroid biopsies, lung biopsies, chest ports, like those kinds of bread and butter, super simple things that, you know, some interventionalists don't really do anymore. But in an effort to try to keep our, you know, we only have so much work during a day for an interventional radiologist, and our interventionalists, we do, I mean, I do everything, everything from AAA to joint aspirations to LPs, like we do almost everything here. Like a lot of our other specialties don't do procedures at all, chest tubes, whatever comes up. Peripheral artery disease, venous work, like everything. But we still don't have enough work during a day for 4 full-time interventionalists right now. And so what we end up doing is, that's why we do all the procedures. Like we don't have any non-physician providers doing procedures just because there isn't enough. And then we do use some locums to cover some of the costs so that, you know, I'm technically PRN, but I essentially put myself on the schedule for like Q4 type of a call schedule. So it's definitely doable, even in a kind of a rural setting. It's just that you're relying on locums or you know, to do some of the call, etc. Essentially, so I don't work that many days in a month per se. I work between, I would say, 12 to 14 days, and 7 of those days are on call. So, but the pay structure is such that it's fine, I guess. So.
Yeah. So it sounds like call is about every like 4 days then when you are doing it during a month.
I usually like to bunch it up. So I'm like they do like us to do like 7 days in a row, so that when they bring in locums, like it's a block, because we have people flying in from, you know, even Canada and California. We have a couple like people who are regulars, so to speak. And so, but there are some times where it's like 2 days or 3 days, or, you know, I cover for my partner, or somebody shows up late, and it's always like the 2 of us that live in town that end up covering, you know, so. But don't worry, we get paid for our time, so.
Awesome. And you talked a little bit, you know, about the cases that you see, like in a typical day, how many cases would you see that you do that are like larger cases versus how many that are like smaller ones that you just kind of use to like fill up the time?
Yeah, so it completely depends, honestly. Like there are some days where I have like 3 or 4 really high-end longer cases, and there's some days where I don't do any of those at all. It's all like thoracic paras biopsies, PICC lines, whatever, tunnel lines. And as far as the number of cases, it's honestly like, it's not, I mean, each case has at least an hour time slot, no matter how small. I mean, sometimes we'll do 30 minutes. But it's because of our staffing. Like in a rural hospital, there are only so many nurses and technologists that I can use in kind of my IR service, right? So a lot of times we're sitting there waiting on the staff. But in that time, I can do other things, like go see patients on the floor, do drain checks and things like that with my nurse practitioners. So we do use nurse practitioners, and that's what they help us with is, you know, writing notes for the inpatients. We see them together and they write the notes for me and things like that, and make sure I see everybody, keep track of all those things for us, because there's the same physician may not be there 2 days in a row, so they keep track of the service for us. You know, as when we do rounds and things like that. Not sure if that answered the question.
Yeah, I think it did. And like you touched on resources a little bit. Sounds like, like you're sharing techs and nurses, and so there's some difficulties with availability there. Like, what other issues with resources do you kind of find that you have?
Well, right now there are severe, staffing shortages everywhere. Like about 2 years ago, I mean, we had 5 techs. I have 1 permanent tech right now and 1 traveler who's leaving soon. And it's like there's going to be a lot of days where we just don't have call in IR available, where like an F tube may have to be done in CT if it's emergent, for example. And things like that. So these kinds of issues do come up here more. Like I wouldn't expect that in a big academic hospital to change how you do a case because a staff member isn't available. And I would say that that's not unique for our hospital. I think that's unique to all rural practices because, as and I don't know why these hospitals aren't giving retention bonuses to staff because surprisingly to them, but unsurprisingly to me, it's hard to recruit new people to North Dakota. I was like, I moved here for love, guys. A tech might not.
Yeah.
I don't know. Unless they're from here. I just don't know. So it's been really tough lately. And some people have, like some of the nurses have left to go to nurse practitioner school, and it's just really been hard for us to recruit new staff. We've been okay with physicians, with our locums and things like that, but other staff, it's really hard. And then the other issue is other physicians. For example, there are certain times where we don't have a vascular surgeon in our hospital. We just don't have enough volume. So that's why we do peripheral artery disease and AAAs and things like that. Emergency carotid stenting. But we do have a cardiothoracic surgeon that does certain vascular type procedures. Like they'll scrub the AAAs with us. We'll do those kind of together. We'll do some hybrid cases, peripheral cases with him. But there's sometimes when, like, if he's not available, the other CT surgeon doesn't do peripheral vascular work, like the locums or whoever is covering. So you just have to be cognizant, not just what staff you have, if you have IR call available, but who else is available in the hospital and what are they able to do, which is not something that people in academic institutions have to think about. Like, do I have a vascular, like, do I have somebody to bail me out today if I do this, is essentially the question. Like, who is available right now to help me if this case goes wrong? And scheduling is a problem sometimes because, I have to schedule, like aortic iliac interventions, but I'd like to have somebody around who could cut on a patient, for example, and potentially help me in some way. So it does become a little bit challenging.
Do you guys do a lot of coordination with other, services then to kind of help with that? So like say, hey, we have this case we want to do. Is this person going to be around, or do you just kind of try to make it work? And
oh yeah, well, I just text the surgeon and I'm like, hey, are you around this day? And he texts me back and he's like, nope, I'm out of town, or yeah, I'm there, no problem. So if I have something big, I know it's a close knit community because we only have 1 permanent, cardiothoracic surgeon. So I just text Peter and I know. And if it's not him, then I like the few locums that come, I know most of them and what they can do by now. And if it's some new guy, then I wouldn't want to do a case when there's somebody I don't know anyway. If that makes sense. I don't know everybody's, like, I didn't see that person's credential packet. Like, I don't know how many of those cases have they done. I prefer to stick to the folks when I know well, if that makes sense. But again, like in smaller hospitals, it's different because I know every physician that works in a hospital. Not just physicians, but even nurses. I recognize every single nurse probably that works in a hospital. It's definitely different in a smaller place.
Yeah, it sounds very different than, working at a big academic university when you're in training and like, you don't really know, people outside of your department as well. So.
Right, yeah. So yeah, we do work very closely, like with urology, for example. A lot of our, some of the general surgeons who are actually contracted to the hospital, and they work very closely. Like we all have our each other's cell phone numbers, and we just, it's easy that way. It's very collegial.
And do you ever have any issues with, like having a C arm be down, not having access to like a CT scanner for a case when you need it, or are you kind of able to help control that?
Well, we have 3 cath lab rooms and 2 IR rooms. And right now, honestly, we only have enough work. We only have enough techs to staff 1 IR room. So we always have the other room as a backup. And the only thing that we can't do in the other room, like it doesn't tilt for LPs, but I don't tilt my LPs usually anyway. So we do have 2 rooms. We have 2 CT scanners for the whole hospital. That's it, believe it or not. We do procedures in room 1. And when we're not using procedures, they scan in both rooms, you know. And that the one where the acute strokes are scanned is the other room, so that we're, you know, we don't want to have a patient on the, so that's why we had the rapid software package installed on the other CT scanner. So, yeah, it can be challenging. For example, when one of the scanners is down, we try to avoid, you know, scheduling elective things in CT until the other CT scanner is fixed, because there's only 2, and if there's a stroke, I mean, I can't do a cryoablation.
Yeah.
You know, it's just not, I can't pull that person off the table with needles in their kidney.
Yes.
Because there's a stroke. So
yeah.
So yeah, sometimes unfortunately it does become an issue, but it's not very often.
And then do you ever have issues with like not having the wire or the catheter that you need, or do you guys kind of stay on top of that to work through those things?
I think there is a shortage of certain things all around. Like there was a time a couple weeks ago where we just didn't have drains, and I was like, can we try a different brand perhaps? Like, you know, for like nephroureteral stents, like they didn't have the lens the patients needed. So, you know, sometimes we do. My technologist is Jen. She's fantastic and she's pretty proactive. And there are some other people in the background that when we don't have something, they know to ask me if that's something they need to look for an alternate thing for, if that makes any sense. But for a rural hospital, we are extremely well stocked as far as the number of types of items that we have. Like for example, like balloon expandable stents, like we have the VBX, the Gore one, and the Livestream. And the reason for that is that each company only lets us consign a certain number because we don't use that many in a year, right? So then we compensate by having more types, because you have to have a certain number of things on hand. And honestly, there is another hospital in town, and they have a, you know, interventional radiology department. And so we go back and forth. If I need something urgently, like in the middle of a case, like the tech will run over to Sanford and they'll borrow something and then we'll give it back whenever it comes in. And our it's the same reps, so that we're like, okay, you guys need to bring this quick because we need to give it back to Sanford. So they usually like will overnight us things, etc. None of our reps live in town, which is also another problem. They fly from Minneapolis or from Fargo. Like none of these places are very close. You know, Fargo is like 2.5-hour drive. Minneapolis is, you know, an hour flight, but there's only like 3 flights a day. So certainly that can be challenging sometimes. But Boston Scientific, I think, there's a couple companies where they have the reps in town, but most things the reps do have to fly or you know, or whatever. So which they do, it's fine.
Yeah, have to do some planning ahead though to like make sure that if you want someone around, you kind of plan that out.
Yeah, I mean, we still do enough cases where they want to sell us things, you know, so.
Yeah. It's nice though that you have also, you know, another hospital around town. Do you have a pretty good working relationship with them and like the interventional radiology group over there, or is there a little bit of a competitive edge between the two of you?
Yeah, I mean, there's always competition. I mean, I would say that, you know, they do more, you know, twice as many cases as we do here. They're bigger. I didn't like their contract over there, so I don't work over there. There's always competition, but I know those guys. I mean, 2 of them used to work at my hospital before, so I know those guys very well. There's a lot of, you know, some doctors used to work over here and then they go work over there, back and forth. There's no non-competes in North Dakota, so we just like go back and forth. It's not a big deal.
Yeah.
And we do Angel Club, you know, when both, you know, staff from both hospitals show up for that event. So it's like, I mean, it's competitive as far as, you know, we want business because we want to stay gainfully employed, right? But
Yeah.
but it's not in a malignant type of way at all.
And you had mentioned, having a clinic, seeing patients on the floor a little bit earlier. Can you talk a little bit more about, what support your hospital kind of provides for you, building a clinical practice to bring in some of those larger cases and like following things on the floor?
So when I first got here 4 years ago, I mean, the clinic was essentially like the NPs were seeing the clinic, and we were just, if we had time between cases, we would go see the clinic. And I was like, whoa, no. So now the physicians, so me and Nick Bradbury, who's the other local interventionalist, we have clinic. The other the locums don't have clinic. So we see about 4 days a month. We have a full day dedicated to the clinic that we see new patients, patient follow-ups, etc. And we see every patient, and we see all of our follow-ups ourselves. We have literally, I mean, a full day. I don't do any. I mean, I usually do like an 8 and an 8:30 procedure, something super quick, and then about 9:30, I'm in clinic, and I'm in clinic for the rest of the day, seeing patients, doing patient follow-ups, running the IVC filter list with the NPs. They always have it. They kind of keep track of all of our patients that we've done procedures on. So sometimes they'll be like, look, Mr. So-and-so called, and this is his question, and I told him this. Is that okay? Like all those sorts of things. It's a huge help to have them kind of help us with that workload and kind of keeping track of all of our patients. And as far as marketing, we do like we had a couple years ago, like the hospital did an ad on the TV where like, you're like, yeah, we do stroke or we do veins, whatever. And other than that, it's honestly, it's more about educating the referrers than the patients. I think that's important. So this is a small community, so like it's more like based on your reputation. And I mean, we have pretty good reputations, so we don't really have trouble with that. The patients do sometimes prefer one hospital system over the other, and you just cannot get around that. I think having primary care as a part of your hospital system, if you're like a hospital-based person, will help, and we're not very strong at that. So I know we lose some patients there. But other than that, I do make sure to, if there's some, if I do a complex case, I'll write an email, or like, I mean, I know a lot of the, even the referrers, so like I'll drop them a text message and be like, hey, I did a procedure on your patient, no names, of course, right? But hey, he did great, blah, 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 or I'll call them on the phone. And at the minimum, I will have them fax the procedure note, and the report, so they know that it was done. So doing things like that, I think, is very important. That's not even, like, we never did that in fellowship. We never learned how to do any of that stuff. How important, those relationships are going to be to your future referrals, especially if something doesn't quite go right. You really want to communicate with the referrer and kind of explain, like, yeah, this was super complex, like this happened, this happened, this happened. Everything's going to be fine, but blah, X, Y, Z. So. And make sure the patient follows up, takes their Plavix or whatever, those sorts of things.
Yeah, you kind of are already starting to touch on this, but we do have an audience question kind of asking if you've done anything to kind of build your practice to bring in those larger cases, those like cryos, those PAD cases, and it sounds like, kind of forming those relationships with referring providers has kind of helped you with that. Is there anything else you do, or anything you think that's unique to a rural setting that kind of helps with that?
Yeah, so sometimes we'll do, like, for example, like next month, we're going to do a dinner for one of the oncology clinics, like providing them with some education, the staff with their education, because that's legal to provide staff with education about interventional oncology procedures that are available, for example. And I'm trying to think of what else we've done. We've done these we used to do these lunch talks. We haven't done those lately, but I think it's time. We're going to do them again over this winter, where one of us drives to local hospitals and we kind of like meet the staff there, and we give them a little brief spiel over their lunchtime, just bring them some sandwiches or whatever. And I think that things like that do bring in a lot of patients. It just takes a lot of time. And I would definitely do more of them if it was my own practice, especially if I'm doing it on my own time. So it all depends on like your compensation plan, because I personally do not like to work for free, if that makes sense. I only do so much of these things without getting paid by my hospital, because ultimately I don't get any more, whether I do PIC clients all day or I do PAD procedures all day. I get paid the same at the end of the day. So so I've been encouraging my hospital, I've been told them, like, I've done all these things on my own time, and now it is time to pay me for doing some of these things and things like that. So, but that's certainly because I'm not salaried, right? So I've turned in my hours. I'm an hourly employee essentially. I work from a certain number of hours, and on call I get paid a certain number of, it all depends on how much I work. So.
And then there's another audience question. Do you find it that it's more difficult to build a practice or professional relationship in a rural setting, or do you think it's easier just because, like, it's a smaller community, there are fewer hospitals in the area?
Both. So I think that if you burn a bridge, everybody will know. So that's number one. You cannot burn many bridges, especially with people who are, not saying in power, but like who've been around here for 50 years. Everybody trusts them. Like, you just can't irritate those people, so to speak. You have to try to be civil, and it's not usually difficult. There is maybe one surgeon that I just avoid, and that's it. So I just avoid, so to speak. But all his partners are great. I don't mind, but then once you gain the trust of the community physicians, then it's really easy, because they all say good things about you, and that one person maybe that you didn't get along with is like, he's the only one, and he also doesn't like half the other doctors. So then everybody knows that you're not the common denominator, so to speak, right? But I can see that if somebody, upset the wrong person early on, or had if you have a really bad outcome early on, like, you can really ruin your practice in a rural community. But if you get along with folks and you're nice, and you have, decent outcomes, average or better, which we do have, we have very good outcomes, then I think that that's all that people care about. And, being polite to your patients is very important. Making small talk and taking the time to do that. I don't poke and run every time, right? Like, as for thoracentesis, sometimes when I know there's nothing happening, I'll stay in a room and I'll chat with the patient and ask how they're doing. Usually frequent flyers, right? So that kind of goes a long way, because sometimes they'll go back to their referrer and tell them, that they like you. So I don't know. I think that. So again, it can be both. It can be both good and bad. You can ruin it early. I will say that in a big city, I think let's say you want to build your UFI practice, right? You can pick like one OBGYN group, and reach out to them, and maybe you don't get along with the other one. Like, that's not possible here. There's just not enough people. You sort of have to, you have a wider, I don't know, you have to be nice to everybody. Everybody knows who you are. I mean, it's just, I go to the supermarket and people are like, hey, it's Dr. Solberg. not with the mask so much, but but before the masks. So And the other thing about rural communities, you really can't let it loose in the town. You have to go to Vegas. Because you can't be seen drinking in public, for example, and things like that. So, and except for in a nice and formal way. Not that I would go crazy or anything, but I have been to Vegas.
And it looks like Dr. Khurana has joined us.
Hi, everyone. Sorry for running late here. I think hopefully you filled everyone in why I was running late.
Yep, you had an urgent case to do, and so we're glad that you were able to make it, and it didn't take the whole time.
Yeah, I'm glad somebody's working around here.
Well, you know what? I'll just chime in. It's funny how it plays into what we're talking about. My patient drove over an hour, and she was an hour delayed. She showed up, her education level is not up to par. She's only in her 20s, has chronic kidney disease, stage 5 from uncontrolled diabetes, and I made an endovascular fistula on her 2 months ago. She just started using it last week, and they were pulling clots. So of course, it took a long time to get her out here, but I'm the only one, who can address that issue, because there's nobody else within 100 miles or even more who are making endovascular fistulas. So another thing to think about when you do rural community medicine, whether it's IR or not, any specialty, is you may be it. That's it. Like if you end up specializing in something that only you do, you have to manage your patients through and through, manage the complications through and through, and the referring physicians are going to see that you're watching the patient from nose to tail. If you're doing things on the patient but you can't follow through on the rest, you're just not going to build that practice rurally here, because as Dr. Solberg might have told you already, a part of this is educating the physicians around you about what you do when it comes to IR. That's probably half of what I do every day, is phone calls saying, and it's met with, oh, I didn't know you can do that. Now, I've only been there for 2 years, so even after 2 years of nonstop work, I still meet a provider every single day, whether a nurse practitioner, PA, or even a physician who just doesn't realize what we do, what we offer, and to what extent. So it's on one hand, it's taxing, but on the other hand, it's extremely satisfying, and it's also, there's a ton of security in that. Imagine doing anything where you're the only one and there's zero competition, and 9 out of 10 times you're saving the day. So it's a double-edged sword for sure. I mean, obviously, when you go somewhere rural, you're going to end up hopefully getting partners, joining teams. I wish I worked closer to Dr. Solberg so we can maybe take call for each other or something, because I've been on call for like 2 years straight. But I am getting a partner in January finally. So if you end up going somewhere and it seems like a lot and you're the only one, just remember that you are building a foundation for the future of healthcare in that entire region. Because let's say you leave, well, you've set the stage, you've set the bar. At that point, the entire community is going to need IR. So it's a beautiful part of being in interventional radiology at this point. I mean, we're young. Dr. Solberg and I are relatively young to some of the guys and gals from 20 years ago who really brought IR to where it is today. But the field is in its infancy still, especially in rural areas. I mean, we are at the very, very forefront of this field, and it's just getting started. So, the rural thing is really an interesting phenomenon when it comes to interventional radiology. So that's nice to meet everyone. Just to give you a little background, I'm in South Dakota, Iowa, and Nebraska. My practice is in South Dakota in a area called Dakota Dunes, and about 5 miles away is a level 2 trauma center, and about 7 miles away is a level 3 center that has a maternity ward, and both hospitals are about 150 beds. We service about 100,000 people, and maybe about 150,000 people if you include the 12 outlying counties of our area. Collectively, it's known as the Siouxland area. That reaches into Nebraska, Iowa, and South Dakota, as I said. We're about 90 minutes north of Omaha, and we're about 80 miles south of Sioux Falls, South Dakota. If you've ever heard of that, it's a wonderful place. And like I said, I moved out here 2 years ago. I joined a vascular surgeon as a partner, and it's one of those rare instances where there's zero turf war, because there's more people's legs falling off than we know what to do with. And so peripheral vascular disease has been our focus, in that kind of, interventional oncology, vertebral augmentation, and then all the bread and butter stuff, dialysis work, embolizations. So it's been very, very rewarding and fruitful. And I was surprised, I'm happy to be here and talk about my experience, but like I said, 2 years is not enough time to really get a grasp of the community intricacies, the relationships that have been built here for 30, 40 years. 70% of the physicians in our area are private practice. There's a lot of old school relationships. For example, me trying to do a port, oh my God, the oncologists, they love me, but those ports go right to the surgeons, and until those oncologists retire, it's not going to be any other way. So you got to learn to pick your battles also in a rural community, because I think I logged on when Dr. Solberg was saying you can't get a drink anywhere without someone seeing you, or maybe have 5 drinks. Well, it's true because everyone knows everyone's business. I mean, you can't. If I get into a little scuffle with another provider about a turf war, everyone will know about it the next day.
Mm-hmm.
So it's really like just, they say, walk amongst the tall grass quietly. Just keep your head down, do your work. You will make inroads. They just happen very slowly. So nice to meet everyone. I'm always available after this talk also for individual conversations, emails, things like that, if anyone out there wants to know more about this area or my experience.
Awesome. We were just talking a little bit, about what makes, like a rural IR practice different than what we might see, in a training practice that most of us are in prior to leaving the safety of an academic practice and fellowship and residency. Do you have any thoughts, Dr. Khurana, on, things that have been different that you've noticed compared to your fellowship?
Well, I did practice for 3 years in Chicago with a private practice, and but from my fellowship, the difference is it's going to be, we don't have all the high-end specialties here. Like we don't have transplant locally. Our oncologists are very good, but I have to remind of some of the current literature and data.
Mm-hmm.
In an academic center, there's not going to be a senior medicine resident calling you about IVC filters or DVT, and like they're going to look it up and know when to call you, when to not. 9 out of 10 times you're going to get a consult at academic center in fellowship that makes sense. 1 out of 10 times you may have to be like, yeah, you really kind of missed the mark on this, you really don't need us. Or if it's a younger resident, you might, not an IR resident, but a younger like medicine resident or surgery resident, you might have a teaching opportunity there and say, hey, why don't you look up the recent guidelines on filters or something. Here, it's like the other way around. 9 out of 10 times, you're really, because they're so used to, and this might be not only rural, this might be all community hospitals, they order stuff thinking that they're ordering you to do it. I got an order once for a TIPS from a hospitalist, and they were like, I'm ordering a TIPS. And I called them and I said, do you know what that stands for? But it's charming, but I've never been met with any sort of resistance to them being like, oh, well, I didn't know what to do, or can you explain this to me? Maybe once or twice, like I've gotten a little, scuffle with maybe a surgeon or a neurosurgeon, and I'm like, yeah, this is not an order, this is a consult. I'm like, I'm going to see the patient and I will let you know if I think it's appropriate to do A, B, or C. And they're like, what do you mean consult? Like, I'm telling you to do this. And so everyone's going to go through that no matter where you are. I just think in rural communities, people are just really grateful that you brought this service line, that you are, as long as you're doing the right thing and you're attentive and responsive. If you're in a rural hospital but you don't want to get called in for stuff, just don't go practice in a rural area. They really need you more than anything else. I mean, and once you provide a little glimmer of what you can offer, they're going to call you forever. So it's more work, it's very rewarding, and there's huge opportunity for expansion. I'm not going to, I'll keep rambling if I don't stop, so please ask more questions, and I want to hear what Dr. Solberg has to say as well. But we'll eventually in this talk touch on the concept of an office-based lab and what that can offer in rural communities as well, because as you might or might not know, it's a model of medicine that is, it's a model of medicine that I think is very beneficial for physicians. It's also beneficial for the patient. And what that basically means is patients are getting more high-end procedures done in the office. When I say in the office, like literally you have a C-arm or a fluoroscopy unit and sedation nurses and recovery and all that stuff, just like you would go into like a boutique surgical center, going into an office-based lab and getting these things done, whether it be fistulograms, peripheral angiograms, venograms, UFE, prostates. I'm even going to be starting cryoablation. And I know some colleagues are doing Y90. So, I mean, there is a huge future in that, but in a rural area, I think it's easier to set up because they champion private physicians, right? You go to these bigger kind of cities and stuff, and there's going to be these massive medical corporations and these huge hospital systems who are eating up all the private practices. So You know, that's it's a tangential topic, and you know, we can talk more about it later if we have time at the end here. I don't think it's really just in rural areas. These things exist all over the United States, even in big cities as well. But you can really make an impact in a rural area by owning your own IR office-based lab.
And that is true, but it is geographic. So I actually looked into that about 2 years ago. I had a market survey done and a pro forma, essentially to see if I opened one of these things, would it be profitable? And the main problem with where I live, where it's still a draw of about 150,000 people, is that it would be very difficult for me to get referrals directly to me outside of the hospital. And that's just because of the way that the primary care is set up here, and the way that the referrers already have pre-existing loyalties. And I chose not to go that route because I guess I chickened out. I mean, I think I could have, but at that was the time when I didn't want to work full time anymore. I wanted to do some traveling and things like that. And I was like, no, I mean, if I do OBL, I mean, it has to be kind of like you, kind of working all the time. And then I just, I'm older than you, I think. So I just wasn't, it wasn't in the cards for me. So all I'm saying is that it is great and it is doable most places, but you have to have a market survey done. Like you have to hire, I mean, I hired a company to do that for me. I hired a accountant to do a pro forma for me. And then, you know, there are, OEIS is an organization that, you know, obviously champions OBL and private practices. And that's where I get a lot of my information. And I know a lot of people now, a lot of good friends now in that circle. So if anybody is interested in that, we can definitely hook you up with the right people to discuss those sorts of things. And as far as your comment on educating the referrals, that's such a great comment, because I'm going to tell you guys my favorite consult in the ER in room 20, not in like bay 1 or bay 2 or bay 4. And then, I mean, we only have 20 rooms. So room 20 is by the door, okay? Not close to where the doctors are. They're like, I'd like you to see this patient in room 20, and I want to make sure patient has massive PE. And once you're in there, could you please just rule out massive hemoptysis for me? And I was like, I don't think you know what either of those terms actually mean, nor that they're not connected. So, I mean, I didn't say that, of course. I was like, what are the vital signs, right? Like, can you tell me the vital signs? And they were normal on room air. So I was like, okay, so the patient does not have a massive PE. But I mean, I spent about 20 minutes educating that physician assistant in terms and what is a clinical diagnosis, and that's just part of rural practice. And sometimes it's the hospitals you have to educate, or another specialist. And in the same time, you have to be open to being educated by other specialists as well. Because again, we have to know more stuff. I don't know, it's hard to, it's like you said, but you have to be aware of more study, you know, the latest studies. There's nobody to ask sometimes, except, you know, my network of IR friends, right? As far as, you know, what would I do for this complex patient and things like that. And I would say that if you're in rural practice by yourself, like, it's really important to have a network of phone a friend available. I don't know, Neal, if you have one. I have a very large network of people that I rely on for things like, you know, should I even do this here? What do you guys think? And things like that. So, and I am lucky that I do have a partner here.
I'm by myself, so I'll scrub out of cases and like literally go into my office and start like calling everyone I know. I'm patients are stable sedated, and I'm like, what do I do here?
I've done that once, so yeah, but I mean, it is what it is, right? If you're the only, because there are times when I'm the only person in the hospital, and you know, the other guy's on vacation and out of town, and then, you know, obviously the locums aren't in town. I mean, there's nothing else you can do, right? So what do you do? But
yeah, these are all really great points that you guys are bringing up. We've kind of, you know, started to touch on this, and in previous webinars in this series, we've kind of touched on, you know, local laws and policies that kind of differ from states to state that like sometimes make it difficult to open up an OBL, especially like, you know, talking kind of about exclusive contracts and make it difficult for providers to potentially open up an office-based lab. Can you guys talk, a little bit about how, like, your research or how you've had experiences potentially in a rural area or in your respective states with these issues?
So in North Dakota, there's no non-competes, and there aren't very many regulations as far as office-based labs. Instead, in fact, there are so few regulations, and I don't even know that any exist. Maybe one I had an engineering company try to give me an estimate on the building, right? And they were like, we don't have the code, like, because it doesn't even exist in North Dakota. It would have been like, I think, the first. I don't even think that it's up here. I know in South Dakota has some, but so it's doable here because there are no non-competes and the laws are lax, essentially. It's very doable. But mine's brief, so now it's on to you since you're actually working on your own one.
No, I have to, mention my partner, Dr. Chad Lorich, who's a vascular surgeon. He took the deep dive. He had a very busy practice up in Sioux Falls, 80 miles north, and he just had an awakening where he wanted to own his own practice. He didn't want to have the runaround of the hospital, try to meet quotas and RVUs and kind of be under the thumb, and they keep squeezing you. And he just said, I'm going to do this myself. And he just researched where in the country was a high density of undertreated peripheral vascular disease who didn't have a vascular surgeon. And lo and behold, he came upon Sioux City. But I think his, so he did put the money down to develop that. He has the business acumen. He has the right consultants. And it is, like Dr. Solberg said, it's a massive undertaking. He works day and night, and he still does, even though we have now 5 doctors. So I'm getting my partner in January, and we have 2 other vascular surgeons. So it went from him, then he hired me, and that was his first smart move. And I'm not flattering myself. I'm just saying it was smart of him to say, like, I'm not going to just do peripheral vascular disease all day. This lab can also be used to do varicose veins, fibroids, prostates, venous disease, May-Thurner, whatever. I can filter retrievals. You can do anything you want there. Of course, when I say that, a key point is there's something called an ASC, which is accredited surgical center. That has a different designation. Some places do have both an ASC and an OBL kind of designation, and based on the tax ID, you can flip between the two. So if you're going to partner up with a cardiologist who does coronaries, you would never do a coronary angiogram and an OBL. You would physically do it in the same building, but you would do it on a Wednesday when your tax ID makes you an ASC, because the reimbursement is completely different. Same thing with, I know it sounds almost like scammy or kind of a little bit like shady. It's not. It's just laws. And that's how billing works, and that's how it works out there. And a lot of people have these hybrid labs that switch between the two, but an ASC can, you need HVAC units and different specifications, and it can be quite pricey to build out an ASC. So unless you have someone doing coronary angiograms, there's really no reason to make an ASC. But that being said, him partnering up with a non-vascular surgeon allowed us to expand our services. And then once we hire other people, it allows us to kind of do things called outreach. Now, the term outreach was misunderstood by yours truly when I moved here. I didn't realize, I thought outreach was like advertising, like, oh, we're going to go to this town 60 miles away and do outreach. And I'm like, well, what does that mean? Just go there and put up a billboard or meet with referring physicians? No, an outreach is actually going out, 60 miles away to a small town that may have a small clinic or a small hospital, and setting up a clinic there and seeing patients there maybe once every 2 weeks, and maybe doing some light procedures there, or coming up with a contract with the hospital to do some light procedures. But that's how you build a practice, because your reach is going to be 60, 80 miles, circumference of where your epicenter is. And patients in rural areas, once you're their doctor, they will drive an hour and a half to come see you every single time. And
5 hours.
Oh yeah.
They will drive 5 hours. They drive from Montana and even South Dakota. It's a different part of South Dakota.
Yeah. Oh yeah. No. And it's like amazing. Their loyalty and dedication, and it's really nice because it's old school. My dad was an internist for 30 plus years, 35 years. And at the end, he said, don't go into medicine. He goes, I have patients calling me on my cell phone asking for refills, calling me by my first name. He goes, the whole like, you know, sentiment of being respected as a doctor is gone. Well, in rural areas, it's still there, I think. You know, of course, not everyone's going to be like that, but people really do trust. And they always say, Doc, I trust you, whatever you say. I said, no. You got to understand the risks and benefits. Doc, don't even want to hear them, whatever you want. I'm documenting this. I mean, like, patient says anything I want. But the outreach concept is very new to me. And in order to do that, though, you can't bite off more than you can chew. If you're going to go ahead and provide outreach, you really got to be dedicated, because that community now depends on your specialty. Those primary cares depend on you for the kyphoplasties that you promised them you're going to come see, and maybe you're going to do there, or that patient's going to drive an hour and a half and get their services done with you. So it's a lot of responsibility, and that's the difference between private practice, I think, to some extent, and also working for a hospital. And this is not a blanket statement, but you know, you got to also think when the people who were at this hospital before I got here were salaried, and they had no incentive to do anything, you know, beyond basic IR, and that's fine. But it's a disservice to the community because these people have nowhere else to go. A lot of them don't want to drive to Omaha. They don't want to drive to the big city. They don't like big cities, and big cities scare them. They rather have lesser care or let their disease go untreated than go to a big city. So, you know, it's just an interesting kind of thing that, yeah, the hospitals could hire somebody and give them a salary, but salaries are higher in rural areas, and there may be less incentive for physicians to really go the extra mile. And it's kind of sad, but it's just the way things are.
Yeah, so I will comment that the salaries in rural areas are changing and not for hire. Because of the stark regulations, the anti-kickback statutes. Now hospitals have RVU metrics and made up imaginary maximum salary caps that they're imposing on physicians, and people are leaving rural practice because nobody wants to get paid Chicago salary in North Dakota if they're not from here. So so that is a problem because doctors are leaving rural areas in droves right now. And you know, obviously you have your OBL, but I'm just kind of like for the hospital-based setting, people, I mean, the reason I work PRN is because of this issue, is because the full-time contract was not acceptable any longer. Like I'm not gonna get paid an academic Southern California salary, or I know, pick a city salary, an academic salary, and work here. You know, non-academic hours, like, you know, so that is a problem.
Yeah, the years of like those dream unicorn jobs of like 15 weeks off and 7 figures, I agree those are gone. And I think what you're saying is, and again, my knowledge of the rural areas and what their salaries are, like we flip through the job ads and we kind of see, but I would agree they're decreasing every year. And I think I think that it's a combination of a problem is that the rural hospitals are getting squeezed and they don't have the resources either. I mean, rural hospitals are closing it as a maximum rate. Unfortunately, if they were smart, they would see that if they invest in IR, their length of stay of patients would go down, their complication rates would go down, there'd be less readmission. So they're not looking at it that they have to spend money to save money. They're looking at it purely as how much can this person generate for us? And it's unfortunately the RVU model for IR is just not very good. I mean, man, if you put an abscess drain in somebody's diverticular abscess, you're saving them going to the OR. That RVU, I mean, the number it's absolute garbage for what we're doing for that patient in the long run, because they're looking at the procedure like, oh, it's not hard to do. But look what it's doing for the whole system, right? So it's a huge, you're right, it's a huge issue.
Well, and even the salaries that you're seeing in the ads, those are like the first 1 or 2 years that you're working their salary. And after that, the salary drops. And that's why like the people who used to work at my hospital now work for the competing hospital. And now they've been working there for 2 years. And now they're leaving that hospital and either coming here or moving to the cities because the same thing is happening over there. So it's happening everywhere. So it's when you guys do interview for jobs, just make sure that you ask about the turnover of physicians and how many locums are people using, and how many of the doctors have been here for more than 5 years, and have there been contract restructuring that has occurred or is being planned in the near future. Restructuring is a very nice way of saying we're going to give you a pay cut for more work, so.
Like they're saying,
go ahead.
No, just know your value when you walk in the door. If you guys are all, trainees and you're about to hit the job market, I was there. I took a average paying job in Chicago, not knowing what my value was. And so, do due diligence. If a hospital approaches you or a big conglomerate approaches you, these big names out there, they have 5,000 employees, 10,000 employees, the names of the ones out there. You're just a number. So do your research of the area, find out who the private practice doctors are, and find out how much strength they have in the community. And if they have strength in the community and the community respects private practice docs, that may be something to look into, is maybe joining one of them. Even doing a multidisciplinary, like if you find some general surgeons and be like, hey, I'm an IR, I'll join you guys. They would love that. I don't think that's out of the question, but know your value when you walk in the door. And I think that when you finish training and you go for your first job and you're interviewing, I mean, it is so overwhelming. Doctors are the worst business.
We might have lost Dr. Khurana.
People, I'm only speaking for myself here. Find someone to read over contracts with you, understand every little thing you're getting into, because whether
you're cutting out. I don't know if you can hear me. Can't hear you.
Yeah, we lost your audio.
Okay, can you hear me now?
Now we can, yeah.
Okay, great.
I agree with everything he said.
Something that I was thinking of while you guys were talking, about how patients oftentimes travel far distances to see you. Do you think because of that, there's like more of a role for potentially telehealth, especially, for follow-up visits after you've done the procedure, to kind of avoid the patient having an extra drive? And then do you also think that you potentially need to think more about, should I be admitting this patient for an extended recovery after a more involved procedure, or have them stay, in the area in case anything were to happen before they get in a car to drive 5 or 6 hours away?
Most of my patients spend the night in a hotel anyway. And if the patient tells me they're planning on driving home, like if their groin is oozing, like I'm definitely more likely to obs them overnight. I just can't have them starting to bleed an hour away between 2 hospital systems. That's just not gonna work. Nobody can hold pressure for that long and drive at the same time. So, So for sure that affects me. And as far as the telemedicine, yeah, I have done some televisits since COVID because the reimbursement got a little bit better. So now we don't have to do it for free, where we would just call patients and not even bill for it before, like just call them on their cell phone and see how they're doing. So that's actually very nice, but most of our patients want to come and drive. They want to see us in person. I know that's kind of hard to believe. But I don't know in my academic centers, like how many funerals of the oncology patients that physicians have ever gone to, but we do that here. Like sometimes we actually get to know the family well enough that we'll be invited to the funeral when the patient dies, so.
The telehealth thing, we did it quite a bit during the pandemic, and then I think the reimbursement was different in Iowa or South Dakota or whatever, all the payer, the insurances, everything kind of changed. And so we're just requiring in face-to-face. But like she said, most patients don't mind coming, and they come with their family. For procedures, I rarely keep my patients under obs unless they're going to have like extraordinary amount of pain. If it's like a liver microwave, those are, or but even for my like UFEs in the OBL and stuff, I send all my patients home, and been lucky so far, I guess. Yeah.
Awesome. We kind of talked a little bit about referrals earlier, but I just want to kind of come back to that. Like, what have been things that you guys have done to get, referrals from other providers, potentially drawing in patients to, self-refer for certain things? And how do you think this differs in a rural setting compared to like an urban setting? Do you think that you need to do, different methods of reaching out to people? Is it more difficult to bring people in?
So I'm going to let Neal, I just want to say one thing about it because I talked about this earlier. So I'm going to let Neal talk, but I just want to say one thing, that it is important to sign up for all like the online things that publish your information, because I had a patient from Fargo, which is like a place that has interventional radiologists, look up varicocele in North Dakota, and somehow like my picture came up, nobody else's. And that patient, like when he made the referral, like even like my staff told him, was like, you know, like, not that we don't want to treat you, but like there are doctors in Fargo who can do this procedure, like the varicocele embolization. And he's like, no, I want Dr. Solberg. I found her on the internet. So like, just make sure that whatever procedures, like whether it's the SIR, whether it's through SIR, where they have the doctor finder, or you go on some of the smaller, like the Venus websites. You know, I don't even remember where I entered this information or how he found me exactly, but just that is, I mean, there is a significant amount of patients that just Googled a procedure in North Dakota and my name popped up, nobody else's. So.
Yeah, that definitely is something that is 100% true. Search engine optimization, or SEO. I mean, you can pay marketing companies to get your name into the internet in a way where because right now, if you Google something in South Dakota, you type in interventional radiology, I'm going to come up first, even though you didn't put my name in Google, because Google knows where you are. So it's optimizing the search based on the location. But you got to get your name out there in the location. So there's a lot of companies that do that type of search engine optimization. But really, when I moved here, I found out every family practice doctor and every OB/GYN, and I just started going office to office. I took half days, and I would just come and I had little cards that say, what I do, all the things I do. And I would see them in between there seeing patients. Like I would just say, hey, Dr. Smith, like, I know you only have like 2 minutes. Just want to introduce myself. I'm new to town. And it was really important to say that I'm a private practice doc. My office is here. So that was number one. Number two was having a robust clinic, seeing the consults, sending a letter back to the referring physician. Dr. Smith, thank you so much for the referral. I saw Mrs. Johnson. This is what we're going to do for her. If you have any questions, please call me. Or just calling and pick up the phone. Be like, hey, John, thanks. I saw so-and-so. We're going to be doing this for her. And when I see her in follow-up, I'll let you know how she does. And they are so appreciative of that. Now, that works in cities also, obviously. Everyone likes that type of attention. But in rural, it's kind of like the way it's done here. Everyone's kind of like, thanks, buddy, for helping me out. Or, and outcomes obviously have to be good. But it's really slow, and it could be kind of debilitating at times to, not have big volumes when you first start. But if you're doing good work and you're responsive to your referring physicians by doing good follow-ups on your patients, you will, and then also being available. There's not a time I'm not available for my referring physicians, and word spreads very quickly. Just that I'm always available, I'm always attentive. I'll, get patients in early if they need me to, or, go to tumor board. Whether or not you're a hospital employee, just find out a way to go to tumor board if there is one. If there's not, start one. And people might think, who the heck is this person? But there's no better way to garner their respect than to try to be academic about what you're doing. And then the last thing is doing outreach. So I mentioned it before, but offering a small community your services can mean the world for that small hospital CEO. Meet with the hospital CEO, say, hey, I can come here every other week for just 4 hours in the morning, 8 to 12. And then that CEO is going to spread the word. Well, St. Elsewhere now has access to interventional radiology from Dakota Dunes, South Dakota. Dr. Khurana is a fellowship-trained interventional radiologist, and he's going to be coming here to see your patients every 2 weeks. He offers these 5 things that have never been seen before in this area. They automatically start referring. I mean, they're just like excited to tell their patients that, oh, guess what? Like, our town of 9,000 people now has an interventional radiologist. Like, theoretically, they don't. I'm only there like 4 hours or 8 hours a month, but it's enough to start getting referrals. And word just spreads. It spreads slowly but surely.
Awesome. And then I just kind of want to touch a little bit, and then we'll kind of more focus on the audience questions that I've been getting, and advice for future trainees. But what are, kind of the challenges that you might see in, finances in a rural hospital setting? More so probably, for like an OBL where you're kind of more responsible for, keeping the doors open and being able to pay for all your catheters and wires and everything. And do you think that, it's more difficult just with the smaller patient populations to break even month by month? Or do you think that there's plenty of work to go around and that there's a lot of patients who need this work who just haven't had access to it before?
Since that's an OBL driven question, I'll take it. Again, I'm learning every single day. I'm learning from my esteemed partner who has built this from the ground up. But what I've learned is that reimbursement for procedures in OBL are very, very good. And keeping your overheads less than 50% is the goal. And that's not that hard to do. Once you have bigger volume, you can, you still have the same nurses and the same techs and the same secretary and the same person who cleans the place at the end of the night. All that stuff is constant. But if you start increasing your volume, of course, you can't work your staff to death. Eventually, you're going to have to hire a second tech and a third tech. I mean, we have 2 procedure rooms, 6 nurses, 6 techs. I mean, we have a full staff of,
Send
14.
me 2 of your techs.
Yeah, and so, but we've had turnover, and I think that being in an OBL, if you're a financial owner of it and you're a partner in it, you're the boss. So you have to create a culture there. Our big thing is, no complaining. If there's a problem, you figure it out, and it's ownership. And so no one, if you work for a big hospital with 500 employees, like they're gonna have these work appreciation days and lack of burnout days. Like it's just a different culture. Like we love our employees and we want them to be happy, but we also tell them that you guys have to make your own way here. This is our business, and our patient experience the second they walk through the door to when they leave, we're controlling that start to finish process. So it better be darn good. And we've had to let people go who don't understand that culture. But every single person working in our OBL has a smile on the face from morning to evening. And you don't see that in a hospital. So it's very rewarding, and I think it's doable. Right now, I don't see any reimbursement changes happening in the OBL that would make it difficult to reach that. There's more than enough disease going around for peripheral vascular disease and everything else I mentioned, venous, putting in ports, dialysis access, fistulograms, kyphoplasty. All that's very doable with a good C-arm. So I think just the big thing is just making inroads with you're going to be a disruptor, because when the hospital sees that you're shifting procedures from their location to your office, they're going to want to basically crucify you and make an example out of you, and they'll probably try to hire somebody at their hospital to outdo you and steal your referrals. I mean, that's basically what the fear is, right? So what I did is I promised the hospital that I would exclusively cover all their IR and all their call for a contract, basically a stipend. And that stipend is way less than what they would have to pay to hire 2 IRs to cover this place. Now, where did that leave me? That left me working nonstop for the last 2 years. Finally, I've saved up enough money to hire a partner. And now I can breathe a little bit and hopefully expand my outreach, and then hopefully have more income to hire a third person. So it kind of snowballs on itself. But the key point to being successful in the OBL was to first satisfy the hospital and make sure that that was taken care of. Once you have that out of the way and your competition is basically, you won't have any, it's just, that's it. You keep growing.
The hospital really wants their call covered above anything else.
Yeah.
It's true.
And we're level 2 trauma, so there has to be IR within 30 minutes. So either they're going to be paying out of their nose for locums, or they can pay me a stipend, which is a lot less, and I will cover that diligently. But I'm probably 70% of what I do. No, so 50% of what I do is not in the hospital. Like I do hospital, I do portal hypertension, I do Y90, I do endovascular fistulas, and anything that's inpatient, I mean, I do it. Like if someone needs a peripheral angiogram as an inpatient because their toe's fallen off or they have a cold leg, of course I'm going to do it there, right then and there. So it's just where I think a hospital makes a lot of money is outpatient procedures. And I think the peripheral work and the vascular work is very, very lucrative for a hospital. So once you can't just open an OBL in an area that has a hospital and just start doing that. They're going to find a way to really, really mess you up.
And do you either of you, this is one of the audience questions, do any like neuro work, any stroke work, any aneurysms? I think Dr. Solberg, you'd mentioned you'll sometimes do carotid artery stents.
So I do. So my callback time is 20 minutes because we do acute stroke. The carotid stents are only bailout. I don't do elective carotid cases only if there's an acute stroke and it requires a stent and the surgeon isn't available or can't, whatever. I usually get him involved if he's there. I mean, can't remember the last time I have had to do one. It's very rare. Oh yeah, we do strokes, a fair amount, and it's just a part of our practice. And those are honestly the most rewarding cases, the strokes. I mean, it's super rewarding. Because those patients if they improve, they improve almost immediately, and the families are very happy. Obviously, the patients are very happy. It's really nice to see that, and it's good morale for our staff as well. But working for a hospital is different than having your own place. So some of the staff don't always have good morale, right? Because of all the changes and COVID and all these things, and they don't feel appreciated by the administration, blah blah blah, whatever challenges there are. And so these cases really do help.
I do not do stroke. I would love to, but we're not a certified stroke center. We don't have neurologists here. We have those neurologists on computers that are rolled around the hospital.
We have teleneurologists.
Wow.
We're certified stroke thrombectomy center, and we use teleneurology for acute stroke. Like, we have neurologists that will see the patient the next day while they don't come in for acute strokes.
Wow. Yeah, so I asked them if they wanted us to build a stroke program, but I think to become an accredited stroke center, it's a massive undertaking.
It was massive.
Yeah, I mean, you got to have that 30-minute, whatever, door to penumbra catheter or whatever you're using nowadays. By the way, I came here for a call case and brought my computer to take this call, but I didn't bring my charger, so I'm going to switch to my phone because this is about to die. So I'll see you guys in a minute.
Okay, sounds good. And then I think for this next section, we'll kind of talk, about how hopefully we've convinced some trainees who are on this call or people who are going to be listening in later on to now consider more strongly, entering a career in IR in a rural setting. What advice would you kind of have for people about how they can best prepare for working in a rural setting as they go through training?
So if you're going to work in a rural practice, you either have to learn about all the different types of cases ahead of time, or you have to go somewhere for your first job in a place where the other IRs can help you get that experience. So for example, where I did my fellowship, it was not, I didn't learn a lot of peripheral artery disease work. I learned that all here, but we're very good at it here. And so it's fine. It was the same thing with stroke. I didn't learn stroke in fellowship. I was mentored here and proctored here to do stroke. And kyphoplasties, we didn't learn kyphoplasties in fellowship. I did few in residency, believe it or not. I did more in residency than in fellowship. So, and now I'm very comfortable doing, vertebroplasty, vertebral augmentation, even, sacral augmentation, all these things. I didn't learn joint injections in fellowship. I mean, in residency a little bit, and when I was an internist, I actually ran in joint injection clinics. I'm very familiar with, physical exam and those things. But as far as the procedures for some of these less common injections or nerve blocks, etc., again, it was mentoring and learning it. And so you just have to either, before you finish fellowship, get some, I don't know if they could give you an elective or something like that, either with like neuro IR or neurosurgery, let's say, or with the vascular surgery for PAD, if IRs don't do PAD at that training center, etc. Or make sure that your first job is at a place where they will mentor you, and you have to kind of let them know what you know and what you don't know. And usually it's not a big deal. Like I came here and I told them exactly what I knew and what I didn't know and what I was willing to learn. And it's worked out splendidly. Like it's great. Like I really enjoy working here, despite all the issues and challenges with rural practice, especially in this hospital-based, hospital setting, with all those changes that have been happening over the last few years. But I'm very happy with my PRN contract. Despite not being incentivized for RVUs or types of cases, we do like doing hard cases and doing the best for our patients. And I mean, that is possible because here you have I think it's a much stronger relationship with the patients and their families. I mean, I had a patient in the clinic, this lady, I didn't know her. She's like, oh, Solberg, I thought this John Solberg in 3rd grade. I was like, yeah, that's my husband. So like that thing happens, like things like that happen all the time. And I did change like the grade so you guys wouldn't know who the lady was. But, these sorts of things kind of happen all the time. It's rewarding. As far as a stroke, for me, it's important because if there's nobody else in town that can do a stroke thrombectomy and you cause a stroke, which I have done. I have caused one stroke, a stroke complication, but I was able to fix it myself, no residual symptoms, you see. So like I personally am glad. It was a cold arm case. After a couple hours after the case, the patient started having stroke symptoms on the contralateral side. I was like, oh, this is right. So I don't know. I am glad that stroke is a part of my practice because if you have nobody else to help you with a complication and you have to transfer somebody to Minneapolis, well, that's going to be too late. So.
I'm back, guys, but I'm just on audio unless someone can turn on my video, but I'm sure you're tired of looking at my mug. So you'll just have to listen to me. No, yeah, so yeah, I wish I could do stroke. Maybe Dr. Solberg, you come down here and help us start a program.
Well, I was here through the accreditation process, so. You're not the first hospital that's asked me in the past year to start a program, but you're nicer than the other folks, so.
We'll talk after this.
Sounds great. Text me.
And Dr. Khurana, we were just talking about, what would you recommend for students and residents who are maybe potentially considering entering IR in a rural practice about what they can do during their training to kind of best set them up for a career in a rural setting in the future?
Well, I think that's a great question. And I would never, if you asked me 10 years ago if I'd ever be in South Dakota working, I would say no way. So I grew up in the suburbs of Chicago and lived in downtown for 10 years. So I think that like if you are a resident and you are or a med student or a resident and you want to do something rural, I'm sure you have ties to the rural community. Maybe you grew up in a rural area, maybe that's where your family is. Then it's understandable. But when people talk about rural IR, I think the only thing different about it is the things we've been talking about, the challenges to provide, world-class university level care in a rural setting. And that's all about building relationships, garnering your resources, and not getting taken advantage of. That's pretty much the same thing anywhere you go. It's just a little different here because of the patient population and maybe some of the politics and the local relationships that are already established, and you're coming into that, very excited and eager to work as a young physician. So the term rural IR, I mean, it's not like we're like, doing angiograms and making your own catheters with steam and like from the 1970s. Like there's nothing like that. I mean, I was the first physician in Iowa to do spine jack vertebral augmentation. I was the first physician in Iowa to do endovascular fistula. I've done 30. Last time I checked, the place I trained at has done 30, and that's a major institution. So it's, the concept of rural IR, I think, goes more towards being the only one in a large distance doing the work, or maybe a small group of 1 or 2 or 3 people doing all the work, and then also just navigating those like interpersonal relationships. And also the patient populations can be different. Like, we've been talking about how families involved and how they respect doctors and they listen to you more, and they're not necessarily the most compliant people. That brings me to another point, is a lot of our patient population is going to be late presentation disease. and people who just don't want to listen, but they're really nice about it. You know, it's the whole like, oh, I know I have to quit smoking. I'm like, yeah, you smoke like two, and they smoke a lot out here. This is, I think I'm speaking only for my area, but like a lot of farmers, a lot of people who do manual labor, I mean, they smoke all day while they work. So it's a very different disease process out here. I mean, you see people in their 50s with like, 20 centimeter SFA CTOs, and you're like, oh my gosh, it's crazy. Yeah, for anyone interested, I mean, I'm sure you have a good reason to be interested, and that's amazing that you have that interest so early on as to want to practice in a rural setting. But just reach out to someone who does. Go shadow them for a weekend. I had a guy who inquired about the job I had posted 6 months ago, and by the time he inquired, it had already filled, and he said, I still want to come out. I said, great. He hung out and shadowed me for a full day. He's a fellow. And I said, you know what? I said, if we have a third position or a fourth position down the road, let's keep in touch. But he was like blown away by it. He loved it. And I think right now he's actively looking for something similar to this. So I think his fiance rides horses, and there's like, we have unlimited pastures. We have gorgeous rolling hills. We have the Missouri River rides right through this.
We live on the same river.
Yeah. So, I mean, yeah. So I think if you're interested in it, just reach out. Most docs who are working in rural areas would love. This is why me and Dr. Solberg are doing this talk, because I think we really love this, and yeah, just reach out to any of us.
Yeah. And the other thing is, I think for people who like social interactions and talking to other specialists and things like that, which I think that interventional radiology is, I think people are more social than diagnostics in like as a group, right? I mean, I know they're individuals, right? But then, I mean, rural practice is like the epitome of that, because relationships are so important in this kind of practice. And I don't know, I really enjoy it.
Mm-hmm. And then there's an audience question. You guys have both kind of touched on how you do PAD work. Definitely, it seems like not all fellowship programs in the U.S. at this time have as much PAD work. A lot of times it goes to vascular surgeons. What are your thoughts on how to work on obtaining good vascular work as a resident, and then if you can kind of make that up based on learning some more basic skills as a resident to do more PAD in your work, if that's what you want to pursue.
Yeah, so for me, again, I didn't do very much PAD. Like we rotated at St. Joe's for like 6 weeks, but it wasn't like the most hands-on as far as the procedures, because Dr. Mahmoud Razavi, like those are like his baby patients. And so I didn't get to do very much actual hands-on work, but so I learned it all here. So if you don't get a lot of PAD training in fellowship or residency, don't let that dissuade you from doing it, because I learned a lot of things here. I read like mad. I had my colleagues scrub in procedures with me to help me, but I was the primary each time. And 2 years into this, I was giving a presentation about PAD in the national conference. So like it's doable. You can learn it. It's I'm not saying go interventional cardiologists on us here and do things completely outside of the box, but because you do have to have mentors available. Like I had Dr. Mahmoud Razavi I would call him on my cell phone and send him images, and I would talk with my colleagues at that, 3 partners at that time here. And then, I wouldn't recommend going off on your own and doing it. Like don't open your own OBL, never having done PAD, and start that way. But I think it's definitely doable. It's something that you can learn as long as you have proper mentors available.
Mm-hmm.
I agree with everything Dr. Solberg said. And, I was at a training institution at Rush in Chicago that did quite a bit of PAD. I think they're doing twice as much as they were doing when I was there in 2015. But here's the thing I think I realized is that interventional radiologists in general, when you come out, I mean, you're already so technically skilled at ultrasound. You're so technically skilled at fluoroscopy and wire management. I mean, if you're doing a PTC and you're trying to hit a non-dilated duct and you're trying to get through a obstructed biliary duct, it's all the same concepts. And I just think that we have the delicate touch and we kind of have the patience, you know, compared to surgeons. And I can say that because my partner's a surgeon, so I can say, you know, they're not very patient people. And when they're like, hey, like, give me the back of the glide wire, I'm going to shove it in there. I'm like, whoa, 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 whoa. And, you know, we're just a lot, we've trained very differently. We think differently. And some of the best interventional, you know, peripheral vascular disease physicians I've met cardiologists who are incredible. I've met vascular surgeons who are incredible, and interventional radiologists, but they're all different. But if you don't get a lot of that in your training, you probably already have a lot of the tools in already learned. You just have to apply it to the disease process. And industry, for better or for worse, whatever you guys want to think about it, industry is very helpful when it comes to going out for a course to learn how to use an atherectomy device. You know, learning how the device works is really important when you use it, you know. So that's what these courses are for. Yeah, they're going to be schmoozing you and trying to get you to stock your shelves with all their stuff, but, you know, use your leverage in the fact that they are teaching you how to do something, and usually they have great people teaching you how to do it, whether it be a cardiologist or whatever. And, you know, there's a lot of conferences going on. I remember right after training, I went to some conferences for PVD, and I was the only IR in the room. There was like 50, 60 cardiology fellows. But, you know, you just have to, you know the data. And then if you don't do a lot of it, just know how not to kill a patient. I think, like you were saying, like, don't open OBL and start doing stuff. But, like, just know that if you're going to be going through a CTO and old lady's iliac, that if you balloon it, it may rupture. And when you rupture an iliac, yeah, you got literally.
You got to know your bailout stuff and have it nearby.
You have to know your bailout, and you have to know what's on your shelf, and you have to know how to act quick and do it in a calm manner. So I think that's all that information is really easily obtained of the do's and don't do's. But probably the rate limiting step is to have somebody locally who can be a backup, whether it be a vascular surgeon or a cardiologist, somebody who knows that, like, hey, I'm going in this, I'm doing this aortic case, I'm doing this SMA case. Are you there to back me up if something goes wrong? I mean, that is, just say it just like that. I mean, you should have no ego when it happens, because how many times do interventional radiologists bail out other services? It's like, that's all we do for a living, right? So
yeah, it's very true. And I think that your intervention training, it's really amazing training. And for example, there was a stroke patient, and I just couldn't, it was so tortuous. And after 30 minutes, I couldn't get up the carotid. I was like, well, I read about direct carotid sticks, so I'm going to do that. And I called the surgeon because I knew I needed him to close. If he couldn't close it, like, I'm not going to angioseal a carotid the first time I ever do a carotid stick. So he's like, yeah, no problem. Let's just do the carotid stick and I'll do a cut down later. I was like, sweet. So he's actually, I don't know why, he was going to get the access. And after like 5 minutes, I was like, why don't you let me try? And it took 5 seconds. So you just don't, you guys, even like all of our, imposter syndrome and all these things, like, you have amazing skill with the ultrasound, and there's nobody else in the hospital that can get vascular access better than interventional radiologists. I mean, of course, there are some unicorns, don't get me wrong, but you really can do it. And that patient did end up giving great, and now everybody in the hospital thinks I'm a badass because I did a direct carotid stick on purpose. But there you have it.
Well, thank you guys both so much for your time. Unfortunately, we have, I think, run our full course of time. But thank you guys for, talking to us tonight. Unfortunately, there are a few questions that we didn't get to. Do you mind if we share your emails potentially for answering any other future questions?
Please do, 100%. You guys can email me anytime, anyone on this webinar. Best of luck to everyone, and please reach out if you need any other questions answered, or even if you want to come visit and chat. I'm very happy with that.
Yep, anybody can reach out anytime. I'm pretty responsive. Twitter chat is great. I get a lot of emails. Sometimes those can get lost, as you guys know. But I'm happy to share my phone number with anybody.
Perfect. And thank you everyone who was able to join tonight. This webinar has also been recorded, so it'll also be available if you have anything you want